would like to begin today with some announcement that you may find a YouTube upload of the program we provide here. At least 3 sessions are now available on YouTube. You just key in the term Palliative Care Thailand on YouTube and you can find one is the reflexology that is already online. Second one is the Tao Garden and empowering. That is the sessions given by one of our volunteers here on the second day. So you can key in the word lยาณการ and you can find that online. And here is distant healing meditation requests. Those who are interested to be a healer, then you may apply on this link and we will provide special training after we conclude this volunteer training program on the 13th. Then the healing meditation will be a special session afterwards. And those who are qualified, having finished at least 4 courses with me and I accepted as a healer, then you can be a part of the healing line and we work on healing together, distant healing. There are disciplines involved that you're not allowed to take information outside from the room or to discuss with any person. We keep the privacy of the patient and their family. We may have a photo of the patient, we may have other information, but these are not for public discussion. All right, those who are interested, you have to apply. So we will invite you. So now it's time for case discussion. I would like to bring a case to you. It happened in a family of one of our volunteers last year. An 80 years old man who was a farmer. He was a farmer living on the outskirts of Bangkok. Married, 6 children, and some of them work with the government, some of them work in the private company. And his health has been deteriorating. His wife is 75 years old, stay with him. And he has been suffering from syncope, from dizziness. He could not stand up or walk about naturally as usual and was confined to bed, very thin. And his heart rate, the maximum heart rate was 50 per minute. He cannot lie down in bed flat. His head has to be moved a little upright, so he breathes. And he had breathing rate about 30 per minute. He had been smoking for 30 years, 2 packages a day for 30 years. He quit smoking just 10 years before his illness, and he enjoyed his life walking to temples, talking to monks, and chatting with some monks in his local area, and his children then take care of the farm, and he was quite content with his life. But concern was that his health has been deteriorating, and he has swollen limbs. His leg became swollen off and on, and he could not ambulate. He couldn't get up from his bed without assistance. But he was not bedridden. He still could help himself in eating and can change his own clothes. But most of his time he stayed in his room watching television. And he enjoyed listening to folk music, playing Luk Tung in Thai, and he enjoyed listening to it every day. But his eldest daughter is a part of our volunteer system, and she was concerned. So we planned a visit to his house, and visited. He was very excited upon receiving us. And when he came up to, he tried to come out of his bed and greet us in the living room. But his heart rate was still slow, 50 beats per minute. Briefly talking to us, he returned to his room, lie in bed. He had early history of tuberculosis 10 years ago. And the disease has somehow taken away part of his lungs. So he had difficulties in breathing, and we noticed the vein gorging on his neck, up here. The vein, you normally we couldn't see a lump of the vein on the neck, but we can see that there's a vein on his neck, and his finger show a sign of clubbing finger. You know clubbing, you know what club is? Normally our finger is not round, but his fingers look like a club. You can search on the Google and you see clubbing finger. Clubbing finger is a sign of chronic respiratory disease. It means his lungs didn't function very well. And he was breathing very deeply, sometimes gasping for air. Averagely, the person has quite lower middle class income. Their children could support, his children could support him in government hospital. So what will be your plan for this case? 80 years old, chronic lung disease, congestive heart failure, and he take a lot of medication from University Hospital, visiting doctors every 3 months, not very frequently. And among the medication to receive, there was nothing about the heart to boost up the contraction of the heart. First, is it palliative care? Then says yes. Is end of life? Could or could not be. It depends on how well he was treated. 80 years old, but very thin. He couldn't eat very well. He was not interested in his food and frail, and also he couldn't walk alone, get out from his bed. But there is no bed sore wound. He was not bedridden. With help of his daughter, he could go to toilet, but take time to come back. They provide some light for him, and he called for help, and the daughter come and assist him to the toilet, and they come back again. Wheelchair. Yeah, he didn't have wheelchair though. At that time, no wheelchair, and it's not possible because the house is too steep. A lot of many steps to his floor, and he was just recluded in his own room. That's all. And the toilet. He moved from his room to the toilet and back, but then forward. His daughter prepared a meal. So the youngest daughter resigned from her work to take care of him. Yeah, the good environment is something that is suggested. We suggest that the patient should eliminate the collectivity of the water immediately because a lot of mosquitoes there. At the age of 80, can you have dengue fever? Yes, you still can have hemorrhagic fever. Once bitten by this mosquito with dengue virus, who knows? And this is something that we concern. But what else that we should look for in this case? He was breathing normal air, but the respiratory rate was 30 per minute. And he was lying on a pillow. He couldn't lie flat on his bed. Exercise at his point, not possible. We can solve some basic problems. First, when we look at how do we approach? First we look at physical, then psychological, spiritual, what else? Social, family, what else? Well, that's concluded. Legality, and the last one is bereavement. He rejoiced when he met his grandchildren. When his daughter brought grandchildren to stay with him, that is his most favorite time. He put his grandson on his lap, and he was very happy. Pardon? But no conflict of interest. He didn't write anything of his will. That's normal for a Thai person. But what we suggest here, he a Buddhist, yes. He enjoyed talking to monks. He loved listening to sermons of monks. To meditate. Meditation could help, yes. But he cannot. Can he live alone, independently? The answer is no. He could not live independently. He depends on his daughter and his wife. His wife is very old. She couldn't assist him to move around. But she helps the younger daughter to prepare him meal. When he take very little food. Very little. Pardon? Food supplement. Okay, that may be good. But what supplement that you suggest? Ensure. Is it expensive? Yeah. Very good. So what we suggest is oxygen. Bring oxygen to him so that he could breathe easier. This guy didn't have oxygen tank in his room, but does he need one? The answer is yes. He needs oxygen. So oxygen was given sometimes for him. And the problem is his heart doesn't improve. Still, the beat about 50 minutes, 50 beats per minute with drop beat still linger on. So the doctor hesitated to give digitalis to him. Normally, a patient with elderly age would be given digitalis to take once a day to visualize the beating of the heart. But in this case, the patient didn't receive any. He received, however, a diuretic pill that is safe for him to eliminate the volume. A lot of water taking out from his blood because that will reduce the workload of the heart. That is one treatment of congestive heart failure. But to give digitalis to a patient, you need a specialist. But he was followed up every 3 months, not very frequently, of course. And his house is about 40 kilometers away from hospital, quite a distance. So food supplement may be too costly for the patient. We suggest higher protein diet. Albumin, egg is encouraged. How many eggs can an old person take a day? How many? 2, 3, who say 5? 5. And only 1 a day. It depends. In this case, he has edema, swelling of the foot. So I suggest him take a lot of egg yolk, because the swelling of the feet, that is a sign. We need to draw water into the veins, into the blood vessels. So a lot of albumin is suggested. So for albumin is from eggs, so take a lot of egg yolk. The patient has no complaint over cholesterol. He was undernutrition. So take as many eggs as you can eat in different form, but in every meal, take it. But he couldn't take very much. That's the problem. Now, what do you expect the person, how far the crisis is going to come? So when you look at the patient, as I told you before, we look into the future. We see, we analyze the condition at hand, and we look into future, project it.
Excuse me.
Yes?
So if I'm not wrong, as much as I catch is at least he can move to go to the toilet. He's not bedridden, but I feel that he's been isolated in the room. Then the family leave him with a bell for the communication. So with my personal feeling and my experience, even my mom is bedridden, but we let her in the bedroom only during the sleeping night time. So once she wake up, we brought her in the common room. So it means that it's good for the patient and also good for the caregiver, I think. Because if we let him alone, then he may feel isolated and he may be in the state of as a patient. And then nobody around him, he may feel he may have a psychological feeling than being as define himself more as a patient and as a dependent. For the caregiver also sometimes, so it's good that he's not bedridden and then he need because of orthopnea, he need to reclining position so that we can put him in a kind of a reclining chair. So I think this kind of environmental changes will make him more comfortable and also will bring easier to the family to take care of him. And then we won't need to worry that something happened out of our vision. Yeah,
that's very good suggestion.
That's important.
Very good suggestion. We try, and she's the one who concerned and walk him about. They don't have a walker. I suggest that he should have a walker to take him slowly on, that he could walk in the room. But the problem is, as soon as he tried to get up from the bed, he had a syncope. He fainted. That is the progress of congestive heart failure is taking over. So he has two serious problems. One is congestive heart failure, maybe some kind of block in the heart, a blockage. And second, his lung is doing badly. So, and the third is his undernutrition. The hygiene was bad because of the undernutrition, but he was still alert. But crisis is coming. We can tell that. Waiting for the last straw. Anything can hit, and he can have a sudden death anytime. So that's what we expect. So even he could speak, he could interact with us, but his heart is about to stop. It cannot rise, it cannot, the beat couldn't exceed 50 beats per minute. If it try to elevate, if we motivate him too much, he died. We can help him by giving oxygen through a mask, and then it will keep him better and breathe better. He should have been hospitalized or not. When we suggest why not you take him to hospital, the patient refused. I don't want to go to hospital at all. He insists, I want to be at home. And most patients want to stay at home all the time. Until one day, he had a very difficult breathing. He gasped a lot more, much more, something happened, and then I received a call from our volunteer, shall we move Dad to hospital because he's now gasping. He couldn't lie in bed anymore. And then, yes, please do so. Now, to which hospital? Which one? So I asked, any member of your family work in hospital? The answer is yes. One of our brother worked at Ramatipati Hospital. And I tell him, bring him there. In Thailand, to have connection or not to have connection is very important. If the family have connection with any hospital, use that connection. So they brought him to hospital, and then to the ward, which is not a common ward, it's a kind of a big room with many beds. Will you have him intubated or tracheostomy done to assist his breathing? That is the question the doctor asked. As the volunteer who trained with us, she was very aware that tracheostomy will not do her father good in the long term. So she refused no tracheostomy. Will there be a CPR? She also checked no CPR. Oxygen, but there are several ways of giving oxygen to the patient. One is the cannula, very simple. In Thai, they call it nuot kung because it looks like shrimps. And that is a very, very small amount of oxygen entering the nose of the patient. So the patient is still gasping. They change to a bigger mask, not enough. So they change to another one because CPAP is a big mask fixed onto the face of the patient with pressurized air forcing into the nose and the mouth. CPAP, you can use that for some time. That is the last step to tracheal intubation. Tracheal intubation is another one. Keep it at last, because once you intubate the patient has to be knocked out of his consciousness. But CPAP has its own disadvantage also, because it has poor quality of the lungs. It can blow up his lungs when the pressure is too high. So it has to be given at lower pressure. And yet he had to sit. Very tiring, even at this. And because of the CPAP, it covered his mouth, his face, he couldn't speak, and his mouth became very, very dry and very, very painful. At the end of life, apart from emotional distress, apart from depression, fear, and the pain that troubled the patient most is the pain in the mouth. That's what he had. Very painful mouth, because the skin, the mucosa of the mouth was cracking. So he couldn't complain, and the air is coming, pushing him all night long. He couldn't sleep. But the CPAP was essential. Otherwise, to have tracheostomy, that is a choice that the family checked out. We don't want that to our dad. He couldn't eat. They tried feeding him to NG tube. He pulled out the tube. I don't want it. If you tied up the hand of the patient, and then you can put the nasal gastric tube into the stomach and you feed, you can also do that. But imagine yourself, your hand being tied up like a prisoner, and you're being fed by foreign objects into your stomach. How will you feel? It's terrible, horrible. So he refused the food. And then the day is counting. 80 years old. His lung cannot revive, his heart cannot come back. So we count the day. How many days left for him? What doctor did was giving morphine, having IV fluid and slowly inject morphine to release pain and discomfort. Morphine also release the air hunger, the rescue drug, as a lower amount, about 3 milligrams per hour. You eliminate all this discomfort, but you have to maintain the dose 24 hours, and slowly the patient slowly dwindled away. Finally, he passed away. But during the time, we have to talk to the family, explain to each member of the family, one-on-one, it's about to happen, and you have to plan ahead, and the time could come at any time. For the family to accept that their loved one, their father, is about to pass away, not easy. And they have family reunion around him, visiting him, saying goodbye, and they forgive one another, give thanks to another, to one another. And he was calm. And the doctor said, well, if your dad has a drop of blood pressure, then I will call you. Then luckily, he has a brother. A son was there. So he was staying with him 24 hours. And late at night, at 2 o'clock, he passed away quietly. That is one of our cases last year. But it took quite some time to adjust the family feeling, to allow them to cope with loss that is so eminently there. But there's still hope that the father will regain health and go back to their house again. But it was not possible. That was one of the cases. Even though we have a member of family who was trained in this course last year, she also has a difficult time to talk to her siblings, to member of family, preparing to accept the fact that her dad is about to pass away. So that is one of the cases. And time passed by, we visit, and I attend the funeral of her dad, and she felt better, and we took turn visiting the family, and they accepted that it was his time, 80 years old. It was quite a straightforward issue, but even though she was trained, even though that she knew what was about to happen, she made a choice: no tracheostomy, no force feeding, and her father died peacefully in the ward with one of the family taking care of him. That also helps a lot. But she felt also difficult. So that was one of the cases that we had last year. Any questions about this? What time? Better not to send? Yes, we can plan ahead. And we may plan ahead and said, well, better keep him at home. let him pass away at home. We can do that also. But in a family, you see, there are many opinions. And sometimes when one person said this, well, the other people said, well, let's do our best. Take dad to hospital. And they have to do something. Most family cannot watch their parents die at home. They feel that they have to do something. So there was a lot of hassle, there was a lot of fight in the family, which hospital should we go to, and whether to let him go there or allow him to die at home. Yes? Yes?
About this case, to us, we are kind of inexperienced. It's difficult to make suggestions whether it's right or wrong. But this case, in my opinion, the patient is, condition is rather helpless. It's very difficult to try to treat or bring back the condition of the health. And the patient is rather content with, past experience living. Wouldn't it be good or better if we try to turn our attention to the family members on the living? We can't do much on the condition of the patient's health, and just a matter of time. But the member of the family, I think rather normal for member of the family not being able to take in the news that their father's passing. Wouldn't it be better if we turn attention to the member of the family instead of focusing on the patient himself?
So we take the family as second priority. Then we'll come to another case when we have to take both together at the same time. But this case, we focus on the patient and we make sure that there is no one who suffer from the loss or death of the gentleman. But the members of the family all accept. We have a discussion with the group, with the member with the brothers and sisters, and we make a clear prognosis that, well, he wouldn't survive for 2 more weeks. If he lives 2 more weeks in extra, that will be our good news. But we don't expect good news. And he lived 10 more days. And he passed away in peace with the dripping of morphine, which helped him to ease off the heart failure and the breathing difficulties. So the family keep in mind that the father is about to pass away. But yet that is difficult for them. So passing away. Yes?
It seems that the dosage of it's gone. Morphine, thank you.
Morphine.
The dosage of morphine is quite critical in this case. Generally speaking, if somebody elected to end in this way at home, is the dosage possible intravenously at home?
Yes, it's possible. In America, they all do that. In palliative care and hospice treatment, usually there's a nurse aide staying at bedside, and they have morphine infusion from a syringe that has automatic feeding into the vein of the patient until the patient is calm, settled, and peaceful. The dose of the morphine, however, varies tremendously. Some patients receive 4,000 milligrams of morphine a day. Believe it or not, very high. But for some, very little. Some patients are very sensitive to morphine. 5 milligrams of morphine could knock the person away, unconscious and in coma. So the work of morphine must be titrated carefully for individuals. And the side effect of morphine include nausea, you want to vomit, sometimes allergic, you feel itching all over the body. And the bad side of morphine is you have sense of drowsiness, sleepiness, like you are in half sleep, half awake situation. That is the thing that I don't like about morphine. But it helps the patient to be calm and pain-free.
Legally speaking, what kind of restrictions or freedoms do we have to keep morphine drips at home?
Restriction here?
Yeah, restrictions or freedoms actually. I don't know what the legality of assisting a person in getting morphine drips at home.
We have a lot of restriction. In Thailand, you cannot have morphine injection at home. However, you can have morphine tablet. And you can, some hospitals have liquid morphine. You take at bedside with syrup and you drink. That is very common in the United States. But now no more, there is no hospital that produces liquid morphine anymore. Once Sirikit Hospital produced it and then it stopped for some reason, no liquid morphine available. But in Thailand, we don't have morphine delivery to home. In the United States, however, they have liquid morphine, injection morphine delivered by DHL, FedEx, to the home of the patient. And you don't have to fill up for morphine requirement because they have computer. And the computer will alert, now this patient will need morphine right now. Mail it. And they mail it to the patient. We don't have the system in Thailand. Not yet. But in America they do. So morphine is for injection delivered at home for the patient. And the doctor just pay visit. And the nurse will connect it to the syringe. And that is very available. But now in Thailand, the patient has to show up to the hospital. They say, hey, I run of my morphine. Hello. So that is a problem. Yes?
In America, there's many cases they are dying because of drug overdose. So I think maybe this can be the reason because they can order some kind of this at home, and it's impossible that the patient can control the use of this kind of drug or medicine all the time because maybe they don't understand the situation of themselves. Because I heard so many cases in America on drug overdose and the patient died. So this can be the case.
But drug overdose, I don't come across it so often in Thailand. Never. But in America, under hospice care, the patient is usually monitored by a nurse aide. Nurse aide, not the nurse. Nurse aide attend the patient, and the nurse come and provide injection, make sure that there is no leak, and the drip is continue 24 hours. And the nurse visit many sites a day to make sure that the morphine dose is administered correctly. I never come across case of overdose by morphine, except the patient intentionally would like to die themselves, but never seen that. In hospital in Thailand, the situation is worse because the doctor hesitate to issue morphine to the last moment. Maybe because they're afraid of addiction to the drug, which is very ridiculous. The patient is about to die and you said, hey, you get addicted before he dies. So doctors were not trained to use morphine very well. We must find a way out. Personally, morphine may be not the best choice. There has been a research done in England 3 years ago. It was published in Lancet or something. There's a case study done on terminal cancer. They all have the same cancer disease, a lot of pain. And the doctor prescribed three medicine, A, B, C, all in white, same amount. They tell the patient, one tube contains heroin, 100% heroin, pure form. One contains cocaine, pure form of cocaine. The third one contains nicotine, pure nicotine. They were diluted and put into the solution and dripped into the veins of the patient. And then the doctor said, now you guess, you get all the three. A, B, C. Which one you guess what? And guess what? All the patients got wrong answer. The most potent drug that they receive, you guess, is nicotine from tobacco. The thing about nicotine is that it doesn't cause the sense of drowsiness. It alerts the brain. It causes the patient to have more concentration and have a better sense of well-being. But so far, not so many trials have done on the scaling of nicotine use for palliative care. We are hooked up by international law to import morphine on particular amount each year, and we can order once a year from one pharmaceutical company. Yes, once a year only, once.
So which company is in charge of the morphine then?
Pardon?
Which company does this?
I cannot tell you that. But they're in charge, and they're a giant company. They monopolize these morphine stuff all over this country. We can order from entire year. Patient die crying. Not only with government-run hospital, even top private hospital of Thailand, patient die crying of pain. No morphine in Thai country. Pardon? They cannot do that. It's tied by international law. You cannot import morphine. You cannot do that on your own. It has to be done only by government agency, and then a private doctor cannot carry morphine into this country. It's a highly controlled drug. So if we can use nicotine, it could be of help. Last year I have a case 90 years old American man who suffered from back pain. He had a herniated disc and collapsed disc, and he couldn't walk. He was on wheelchair. 90 years old. What can I do? I now rent a house at Pattaya. I'm living in Pattaya. So what can I do to help my father to make him better? Morphine? Difficult. So I say, why don't you buy? So nicotine pad is used for quitting smoking, but it can be applied in case of chronic pain. For a normal person who don't smoke and you put nicotine pad on yourself, you feel dizzy or even sense to vomit. But for people who have chronic pain, that is a rescue drug. Put on the skin. You don't have to get permission, no prescription needed. Put on the skin of the patient. It serves the purpose. Yes?
In addition to nicotine, of course, there is a lot of research going on with another narcotic substance, which is an alternative to an opiate, and that's marijuana.
Yeah. Yes, marijuana may be a good drug of choice as well. It's allowed in the United States. It's allowed in California, for instance. So if you smoke marijuana, if you have illness, you have a cancer, then it's okay. Marijuana also increases the sense of appetite, so the patient eat more. So even the worst case, all these addictive drugs also have this good side that we can use them. But I don't think that we can find marijuana easily in Bangkok, do we?
I don't know.
You don't know? Well, but we shouldn't be afraid of addiction. E-cigarette is another choice. E-cigarette, you can put nicotine solution and the person can have puff. And it's controversial whether it causes cancer or not, but it's a way to alleviate pain. Better than dripping solution.
Any
Yeah?
toxicity issues?
The dose?
Toxicity issues with
No. The dose is titrated by the patient. Some patient you have to push the dose very high, even for morphine. Normally, at the dose of 3 to 5 milligram per hour, dripping is okay to eliminate pain. But for some, you have to increase to 10. You have to titrate it. But for some, you go up to 1,000 a day. And they allow that in the United States. So morphine, the range of morphine application varies a lot. There is no scale which say you cannot apply more than this, or else you get toxic adverse effect from the drugs. No. All right? See you tomorrow.